Assalamu alaikum and good evening, dear physicians. After a long break of World Cup, we start the program again. This is our 81st session of lecture series organized by ECG Study Group, ECG Basic and Beyond. The topic of our today's discussion is patients with congenital heart disease, how to interpret ECG. And today's speaker is Dr. Naharuma Ayuhada Chaudhary, Associate Professor, Department of Pediatric Cardiology, National Heart Foundation Hospital. Before the start of the session, I'd like to request Professor Rafiq Ahmed sir to speak about Dr. Naharuma Ayuhada Chaudhary, and then we proceed with the lecture. Rafiq sir.
Thank you. Good evening, everybody. Assalamu alaikum. So Naharuma is well known. She is Associate Professor of Cardiology at National Heart Foundation, one of the rising stars in pediatric cardiology. And this is a very important field for us because Bangladesh adult cardiology is well developed, adult cardiac surgery is well developed, pediatric cardiac surgery and pediatric cardiology is still a growing field. And I'm happy to see somebody like Naharuma to work on this field. And she's an excellent speaker. I hope you'll enjoy it. Naharuma, please start your talk.
Thank you, sir. Slide দেখা যাচ্ছে। Does my slide is visible?
Yes.
Okay, thank you. It is a double pleasure for me that we ended 2022 with the ECG in congenital heart disease normal variant, and we begin 2023 with the congenital session again. So it is our pleasure, we are privileged, and the kind words always from our seniors take me one step ahead. And with the very wishing a happy new year to all of us, I want to start my today's talk. And today I'm going to tell about the ECG in congenital heart disease, how to interpret. It is an insensitive tool for diagnosis of congenital heart disease and reflect the hemodynamics and clue to diagnosis. And it is very important to understand the underlying physiology is important. It is nothing but a graphical representation of the chamber dilatation or chamber hypertrophy due to the congenital heart disease. We have to correlate clinically and put a diagnosis. And sometimes the ECG helps to cross-check the echo. Like if a ASD secondum and we are getting a P-axis abnormality, then we can tell the echocardiographer that please check is there any sinus venosus ASD present or not, because we know that P-axis abnormality sometimes present with the sinus venosus ASD. So ECG is very helpful tool. And to read out the congenital ECG, we have to know some terms like that normal position of the heart that we label as situs solitus. Basically, situs solitus labeled visceroatrial situs. What does it mean? Visceroatrial situs means my visceral organ, right side of the liver in right side, and stomach and spleen on the left side. And what is atrial situs solitus means the right atrium in right side and left atrium in left side. And what is situs inversus with dextrocardia? And it is means the right-sided chamber now turns on the left and left-sided chamber on the right. Now, the base to apex is directed towards right. This is dextrocardia, and there are variable complexities present. Today, I am not focusing on that. And does the ECG can figure out the situs? Yes, obviously, and it is very easy to diagnose a normal situs. And if we know that sinus node is located at SBC RA junction and the electrical current travels from the SA node to AV node and the direction is toward leftward and downward. So in lead 1, we get the positive deflection of the P wave in lead 1 and AVL, and it is away from the AVR, so we get the negative deflection of the P. So this is the normal P axis, and this normal P axis correlates with the visceroatrial situs. And the normal situs solitus has P wave in left, just I have mentioned now, left lower quadrant, positive in usually in lead 1 in AVL and negative in AVR. So we determine the situs. Now we will determine the situs inversus. And now the right atrium in left side, and now the electrical current travels from the left quadrant, left to rightward and downward. So now we will get the negative deflection in lead 1 and AVL. The P wave will be negative deflection lead 1 and AVL, and now it is going towards the AVR. So we will get the positive or equiphasic to the AVR. So the inverse means right axial, right axis of P wave indicate that situs inversus. But it might be also ectopic rhythm from left atrium. Means if left atrium is on left side and there is ectopic rhythm, it can also present like right axis of P wave. So we have to ensure that. And next to the situs conformation, we have to know the position of the thorax and the levocardia or dextrocardia. It can be figured out with the chest lead from V1 to V6. And we know that the RV is less dominant in adult and LV is more dominant. LV mass is more prominent. So the precordial R wave progression correlates with the position of the cardiac mass in the thorax. And in levocardia, there will be R wave progression from RS in V1 to QRS in V6 and the transition in V3 and V4 level. So this progression tells us that the LV apex is on leftward. So how to identify the dextrocardia? Now we are getting the LV mass in the right side. And so we are getting tall R in V1 and there is non-progression of the R wave and we get the small R wave in V6. So this non-progression is tell us that this is the case of dextrocardia. And how the mesocardia tells means base to apex in middle position. So here the mid precordial lead is that shows the tallest R wave, which regresses in V5 and V6. So now if we summarize that situs solitus, normal P axis tells us the situs solitus and right axis of P wave indicate the situs inversus. And levocardia tells the normal progression of the QRS from V1 to V6 and dextrocardia non-progression of the QRS. So next to that, we have to check the ventricular relation. We know the cardiologist, adult cardiologists mostly get the corrected TJ in adulthood. So there in corrected TJ, there is atrioventricular discordance. That means the left ventricle goes to rightward and right ventricle to leftward. So how it can be identified? This is very much easy. If we know that the septal depolarization is from left to right, so we get a small Q wave for the septal depolarization in V5 and V6. And this tells us that the LV is in left side. So what happens in ventricular inversion? Now this LV goes to the rightward and the septal depolarization now reversed. And now we will get the Q wave in V1. So absence of the septal Q wave may be subtle sign of the ventricular inversion. This small Q wave tells us the very major thing that there is ventricular inversion. And something clues we get from the QRS, and we level two terms, clockwise loop and counterclockwise loop. It depends upon the ventricular mass and the electrical current that travels through the mass. Now what we have seen, this is from the foot end, and RV is less mass and LV is more mass, and in we have told that that RV has less, so we get small r, and R is in progression, and in V3 and V4 what happens, there is equiphasic R and S. This is called sudden transition, and this transition happens clockwise. So this is called clockwise loop. And what is evident by this in ECG? We get small Q wave in inferior lead, like lead 2, 3, and AVF. And what is counterclockwise loop? If this transition, that means this equiphasic RS is getting earlier, that is counterclockwise loop. And this is evident in ECG that Q wave we get in lateral lead 1 and AVL. So clockwise loop is Q wave in inferior lead and counterclockwise loop in lead 1 and AVL. Why it is important? Because most of the healthy person have clockwise loop. This is the small Q wave. And most of the congenital heart disease, we also get this clockwise loop. And what happened in counterclockwise loop? This is small Q wave in lead 1 and ABL. And we get mostly in the inlet VSD, endocardial cushion defect, tricuspid atresia, some form of double outlet right ventricle, some form of single ventricle. And we have to remember that this counterclockwise loop is always associated with left axis deviation. So today we are not focusing all the congenital heart disease. We will try to focus on most common heart disease. There are two group of heart disease like acyanotic and cyanotic. And in acyanotic, there will be increased pulmonary blood flow shunt left to right shunt like atrial septal defect, ventricular septal defect, patent ductus arteriosus. And cyanotic, I will just focus on tetralogy of Fallot. So I am starting with a scenario, 7-year male child with wide and fixed beat of second heart sound having ejection systolic murmur. This clinical feature tells us some story, and in echo we found there is a mid septal defect in the atrial level, and in X-ray there is right atrial enlargement and cardiomegaly with some form of increased pulmonary blood flow. So this is the ECG of this baby. If we see, there is a lead 1 negative and AVF positive. So the axis is right axis. And if we see the 2, 3 AVF, there is small Q wave. So this is clockwise loop. And we know that RSR pattern we found in V1, this is suggestive of ASD secondum. So ASD secondum is the most common congenital heart disease. What the ECG tells in ECG, it not only diagnoses the ASD, but also tells some scenario that where the ASD is located. We know that there is 4 types of ASD. It is secondum type, primum type, sinus venosus type.
কই গেল
কামরুল আমার মনে হয়
এক
মনে হয় স্যার ওখানে কারেন্ট চলে যায় ওয়াইফাই চলে গেছে
সমস্যা মনে হচ্ছে
কারেন্ট চলে গেলে তো ওয়াইফাই
নেটওয়ার্কে একটু সমস্যা হচ্ছে সব জায়গাতে, আমার এখান থেকেও চলে যাচ্ছে আবার ঢুকতেছে।
তুমি নাহরমাকে একটু ফোন করে দেখো, মানে
আমি এখনই করতেছি।
নাজমা কথা শোনা যাচ্ছে না।
Sir, does my slide is visible, sir, now?
হ্যাঁ ওকে
Yes.
Sorry, it was my laptop was in problem. Sorry. Okay, I was telling that ECG is not only need to diagnose the ASD, ECG also tells us few story that where it is located and what is the amount of shunt. Is the ASD small? Is the shunt is magnitude is large? Or there is pulmonary hypertension is there or not? Or severity of the disease. We know that for this that I told the hemodynamics and physiology and anatomy is very important to know in every cardiologist. We know that ASD is second and there is left right shunt and there is a right-sided chamber dilatation due to volume overload and we get the RBB pattern. And if we see the terminal portion of the R prime, this is due to RBOT dilatation. So the more RBOT volume, RBU volume overload, the more will be the magnitude, the tall R with terminal portion. And this tells us the magnitude of the shunt. And then we can tell, we know that ASD secondum usually have normal axis or right axis, but what about the ASD primum? There is endocardial cushion defect. And what happens, we know that from the AB node, electrical current travels through the bundle of His, then the left and right bundle branch and left have anterior and posterior fascicle. And in there, when there is maldevelopment of the endocardial cushion, there is maldevelopment of the anterior fascicle. So we get in ASD primum, left axis deviation and counterclockwise loop. So this is the cause why we are getting the axis difference in primum ASD. And how we determine the sinus venosus ASD? We know there is a defect in the SVC location. So when there is a defect, the sinus node sometimes is not located in usual site. It may be towards the left lower quadrant. So it was towards near to the AB node. So sometimes we get abnormal P axis and short PR interval. So it can, the axis of the P and QRS can tell and can classify the ASD. And the severity of the pulmonary disease, how can be classified? By the RSR pattern. If we know that initially there is RV volume overload and progressively the pulmonary pressure increases. And when there is severe pulmonary hypertension, it becomes that RSR to monophasic R or RVH strain pattern. So these RBB pattern and RV morphology of V1 tells us the severity of the ASD. My slide is not moving. Does my slide is visible?
No, Naruma.
No.
হ্যাঁ,
আমার
ইয়ে তো
slide
clear-
দেখা যাচ্ছে কি দেখা যাচ্ছে না?
Not yet.
Not yet. Okay. Then I have to again share.
হুম,
Where is my share screen?
আমরা তোমার ল্যাপটপের ইয়েটা দেখতে পাচ্ছি কিন্তু স্ক্রিন শেয়ার বাকিটুকু হয় নাই।
আচ্ছা স্যার, আমি ওটা মুভ করছিল না, আমি দেখি এখন আবার শেয়ার করার চেষ্টা করছি স্যার। আমার
স্যার,
স্লাইড দেখা যাচ্ছে স্যার?
কম্পিউটার শেয়ার হচ্ছে, স্লাইড অন হয় না।
এখনো স্লাইড দেখা যাচ্ছে না স্যার?
না,
আহ,
ফোল্ডার দেখা যাচ্ছে। ইসিজি ইন
কিন্তু আমার
CSD
এখানে ইউ আর স্ক্রিন শেয়ারিং স্টপ শেয়ার, মানে আমি আবার স্টপ করে তারপর আবার অন করব?
হ্যাঁ।
এখানে মাল্টিপল খুলে রয়েছে, আমি হয়তো বা কেটে দিলে যদি ইয়া হয়। এখন কি দেখা যাচ্ছে স্যার?
জি জি
এখন দেখা যাচ্ছে।
Thank you, sir. Sorry, sir. My next case, 4-year female child with a wide and fixed split with second heart sound with ejection systolic murmur. And if we, sir, আমার slide move করে না।
আরে বাপ রে, হ্যাঁ রে, সিনেমা মানে ভালো আছো তোমরা?
I can't move my slide.
এখন চেম্বারে না প্রদীপ, আমি বাসায় একটা প্রোগ্রামে আছি। হ্যাঁ বলো। আমি আচ্ছা, তুমি আমাকে
আতার
একটু
ভাই মিউট করে নেন, আতার
আমার-
ভাই মিউট করে নেন।
নারুমা
স্যার, আমি কি আউট হয়ে আবার ইন করব?
আউট হয়ে পিসিটা একটু রিস্টার্ট দিয়ে নাও।
আচ্ছা স্যার, আমি তাহলে একটু আউট হয়ে যাচ্ছি, কারণ আমি
ম্যাম
খুলতে
আপনি,
পারছি বাট আমার
আমি
হ্যাঁ।
একটু বলি ম্যাম, আপনি পুরো ফুল স্ক্রিন না দিয়ে শুধুমাত্র প্রেজেন্টেশনটা অন করে একটু দেখেন যে স্ক্রিনে কতটুকু ফিট করে, তাহলে ওখানে যদি দেখা যায় আর পুরোটা দেওয়া দরকার নেই।
একটু কষ্ট হবে, কারণ হচ্ছে কমপ্লেক্স জিনিস তো। আমি একবার আউট হয়ে ইন করি।
হ্যাঁ হ্যাঁ ম্যাম, সমস্যা নেই, আপনি ওটাও ট্রাই করতে পারেন, সমস্যা নেই।
ওটা কি কার কাছে পাঠিয়ে দিয়ে তারপরে দেখানোর ব্যবস্থা করলে ভালো হয়? নাবিলার কাছে পাঠিয়ে দিয়ে। রফিক স্যারকে দেখে মনে হচ্ছে ফ্লানেলের শার্ট। শীতের পোশাক।
স্যার মিউটেড।
সরি না, এটা আমাকে আমাদের এখানে একজন আছে, আমাদের সিনিয়র কামাল ভাই। উনি ঢাকা শীত কেমন পড়ছে?
খুব অনেক শীত পড়ছিল, আজকে বিকেলের দিকে একটু ঠান্ডা কমছে স্যার। অনেক বছর পরে আমরা গরম জামা পরতেছি আর কি স্যার। 5-6 বছর পরে এরকম শীত আসে।
শীত কিন্তু আমাদের ওইখানে লাস্ট কয়েক বছর কম, মানে ওয়েদার ডেফিনেটলি চেঞ্জ হচ্ছে।
জি স্যার।
এইবার একটু বেশি শীত পড়ছে।
বাফেলোর
হ্যাঁ,
দিকে তো মানে স্নো স্টর্ম হচ্ছে না?
সাংঘাতিক। হাফিজের এখানে তো একটা নাম করা একটা ইনজুরি হয়েছে। হাফিজ,
নাজমা, তোমার গলা শুনতে পাচ্ছি না। নাজমা, ওই যে স্ক্রিনটা হোয়াইট করে দাও, ওয়াইন কাপে দাও।
শোনা যাচ্ছে স্যার এখন?
হ্যাঁ এখন শোনা যাচ্ছে, তুমি ওয়াইন কাপে দিয়ে স্ক্রিনটা বড় করে দাও।
স্যার, আমার স্লাইড কি দেখা যাচ্ছে স্যার এখন?
এখন খুব ভালো দেখা যাচ্ছে।
হ্যাঁ স্যার, কাজ করছে স্যার। থ্যাংক ইউ স্যার। Sorry, sorry, sir. I'm not so much expert in technical problem solution. Okay, 4-year child with wide and fixed feet with ejection systolic murmur. And if we see this, this is lead 1 positive and ABF negative. So this is left axis, and if we see that small Q wave present in lead 1 and ABL, and we know that presence of Q wave in lead 1 and ABL determines the counterclockwise loop. And next to that, RSR pattern, which is suggestive of volume overload, and it is due to ASD, second ASD. And these are the findings that left axis deviation, counterclockwise loop, and RSR pattern in V1. So this is suggestive of ASD primum. So this axis and clockwise, counterclockwise loop tells us the classification of the different type of ASD. And next to that, 3-year female asymptomatic child, she is a known case of ASD. And here the axis is normal axis. But if we see the P wave in AVR, it is equiphasic or slightly upward, and it was negative and negative. So there is abnormality of the P wave. And if we that short peer interval, and I have just mentioned that in sinus venosus ASD, if there is sinus node is not in usual site, the axis maybe comes from the lower quadrant, and it may be near to the AV node. So there is peer interval short. And if we see the QR pattern, this is RB blocked volume overload due to volume overload. And this is suggestive of ASD. So this ASD is sinus venosus ASD. So this P-axis, short peer interval, tells us that this ASD is sinus venosus type. And this is 1-year male child with ejection systolic murmur. And here also echo showed a large ASD. And here the axis is lead 1 is negative and ABF is positive. So this is right axis. And if we see the P wave and P axis is normal here in positive in lead 1 and negative in ABR, and we get the monophasic V1. So monophasic V1 is suggestive of that there is a RV volume overload is turning with strain pattern here, monophasic R with strain pattern. This indicate the volume overload is now going to hypertrophic RVH. So 1-year male child, it is not usual due to for this large ASD, it is causing severe pulmonary hypertension. And in previous session of my, Wadu sir was asking me what are the red flag signs. So if a patient comes to a cardiologist with this ECG, we know that usually in ASD we close preschool age at 3 or 4 years, but now the baby is 1 year. And in ECG, we are getting that severe pulmonary hypertension. We have to think about that. We have to refer this patient to a pediatric cardiologist to that for shunt closure, early shunt closure. We will not wait for this baby. So this also tells us the severity of the ASD. And another very important thing, if we get this crocheted sign, what is this? Broken brow needle. This sign, if we get in the lead 2, 3 ABF in inferior lead, it indicates this is a large ASD. So this is also, I can label it as a red flag sign. And now this 32-year male with a known case of ASD with severe pulmonary hypertension, the axis is right axis. And if we see the P is normal axis, and if we see in lead to the P pulmonally, tall P, and if we see that QR pattern with strain, it is also very suggestive of that severe pulmonary hypertension. And if we correlate clinically, this patient most probably become inoperable. So this can summarize that in ASD secondum, RBB will be present in all cases. In ASD secondum, right axis or normal axis, and crocheted sign in large ASD can be present, and PR prolong may be present in familial ASD. In primum or ASD secondum along with RBB, we will get left axis deviation with counterclockwise loop. And we know that in ASD primum, they are sometimes present in cleft AML, which produces AMR. So it can be also LV forces can we get in ECG. And sinus venosus ASD, usually we get abnormal P axis, but sometimes normal axis can be also present along with this RBB and right axis deviation. So these, I told that these RBB can tell us the magnitude of the shunt and the severity of the shunt. This is a small shunt, but now the terminal force is tall. So this is large shunt. And now this is monophasic with strain pattern. This is severe pulmonary hypertension. And now this is QR pattern with strain along with right atrial enlargement. This is most probably inoperable. So next to that VSD, just going through a case that a 3-year male child having repeated arterial and feeding difficulty with pansystolic murmur in the left lower parasternal area. And we know this is the classical feature of the VSD left-right shunt. And this is the echo finding, that is perimembranous area. There is a VSD, and there is in X-ray, there is cardiomegaly with increased pulmonary blood flow. And this is the ECG of that patient. Here lead 1 and AVF is positive. So this is the normal axis. And if we see that in V1, their RV is prominent, and LV that we get, LV is also prominent. So there is normal axis with biventricular forces. This is the normal criteria of a VSD having mild pulmonary hypertension. And we know here also we have to know the hemodynamics and the anatomy of the VSD, because not like the ASD, but VSD also can be classified to see the QRS axis, normal axis, right axis, or left axis can classify. And also the amount of shunt, how it can be identified, the LV forces. We know there is in VSD, there will be left to right shunt, and blood will go more to the pulmonary artery, and more blood will comes to the left atrium and LV. So there will be left-sided chamber will be enlarged, and we will get LV forces in VSD. And when there will be more pressure in the pulmonary will develop, the RV systolic pressure will develop, RVH will develop, Eisenmenger will develop. These are the consequences, and these are the ECG findings that tells us the severity of the VSD. And we are going to show a few examples. This is a 6-month child having the feeding and respiratory difficulty. And these are the ECG finding that in lead 1 positive, AVF positive, so it is normal axis. And if we see the P, this is white P mitrally. And if we see in V1, there is tall R, deep S. And if we see the V6, there is LV forces, means tall R in V6. So there is biventricular forces. The most important, that is V-level Katz-Wachtel phenomenon. What happens in V3 and V4? There is equiphasic R and S. If we find in a case of this type of ECG in a VSD patient, that is also a red flag sign that this patient have to be early closure of this shunt. Though the patient is all 6 months, but when we are getting this change in the ECG, we have to think that this patient has to be closed earlier. So this is a large VSD with severe pulmonary hypertension. This is 1-year female with mild symptom. And here we are getting that lead 1 positive and AVF is negative. So this is axis is left axis. We know usually all type of VSD have normal axis, but here we are getting left axis. And we are getting Q wave in lead 1 and AVF. So this is counterclockwise loop. And along with left axis and counterclockwise loop, we get LV forces. And we got the Q wave in V6, and this Q wave tells the volume overload of the LV left-sided chamber. So this is the left axis with counterclock tells us the inlet VSD. In inlet VSD, endocardial AV canal defect, ASD primum. There is defect in the endocardial part. So there is maldevelopment of the left anterior fascicle. So this patient present with inlet, this patient present with left axis. So this axis helps us tell the classification of the ASD. And if a echocardiographer miss the inlet VSD, we can tell by cross-checking this ECG that you can check, because inlet VSD surgery we cannot close by transcatheter closure, and in surgical there may be chance of pacemaker. So counseling is very important, and ECG can guide us this. And 10-year male previously symptomatic and now become asymptomatic. This is very much important, because most of the mother and parents are happy that my baby was previously symptomatic and now become asymptomatic. This is very alarming sign for clinically that this patient might go irreversible reverse shunt. And now we are getting that lead 1 negative, AVF positive. So this is right axis, and there is P pulmonary. And if we see there is tall R with strain pattern, RVH is present. And if we see that LV, there is no Q wave. So there is no volume overload in left sided. And this is very much a warning sign that right axis with RVH with no LV volume overload, it is most probably inoperable. So in post-tricuspid shot, QRS axis is normal or rightward, and leftward axis indicate endocardial cushion defect or inlet type of extension. And in older children with right axis with RV strain suggestive of pulmonary obstructive vascular disease, and LV forces correlate with the degree of pulmonary blood flow. The more will be pulmonary blood flow, more will be LA return, our LV will be more dilated. So this is a good sign for closure of the shunt. And increased pulmonary vascular disease or Frank-Eisenmenger syndrome will have normal LV forces that we found our last cases. And it is very much important I put it here because most of the patient when comes with a echo dilated cardiomyopathy, we if a echocardiographer miss something, that the patient may be treated like a viral myocarditis, but it will be crime if we miss this ECG. This ECG we get a Q wave, prominent Q wave in lead 1 and AVL, and also ST depression in V6. When adult cardiologist will find, they will tell there is ischemia, and we know that coronary might be a chance, coronary may be a cause. In a 4-month child, in a small kids also can develop a coronary abnormalities. This question is asked in previous session to me. This patient has dilated cardiomyopathy due to abnormal origin of the left coronary pulmonary artery from the abnormal coronary artery from pulmonary. So if anyone miss this in echo or in ECG, it will be a crime because this patient is correctable. And if we find in 2 years or 3 years, we can't do anything because that patient irreversible damage of the coronary and that ischemic part, we can't do anything. So if this patient comes to earlier, it will be our duty to find out through this ECG. And lastly, tetralogy of Fallot's. And we all know that in tetralogy, there are 4 components. There is infundibular or valvular stenosis, which causes RV hypertrophy. And there is a large malaligned VSD, overriding of the aorta. There is right to left shunt. Now, what is the important? These are the evident by ECG, and ECG can diagnose it off, but many more things can tell this ECG. We know the LV size depends on the pulmonary flow. If the more pulmonary flow goes, there will be LA flow will be more and LV size will be good. But there is severe stenosis, less blood will go to the pulmonary artery, less blood will come to the LA, less to the LV, so LV will be small. So the severity will tell upon the size of the LV also, and also it tells upon the there is MACPA present or not. So this is a 2-month child having saturation 72%, having second soft systolic murmur, and this is right axis. And we found that clockwise loop in lead 2-3 AVF. And there is a monophasic R with strain pattern. So RVH is there. And we know all this, but one important thing, there is sudden transition. What is that? In V1 to V2, we suddenly get this S wave. This is as because there is large VSD, there is no septal, there will be shunt and there is deepening, and we get this S wave. And this is sometimes helps us to diagnose a tetralogy of Fallot's. And how it tells the severity. Now, clinically, we are getting that it is 56% saturation and a soft faint systolic murmur. It indicates there is less blood is going to the through the pulmonary valve. So this is a severe top clinically. And now ECG, how it helps the axis. It is right axis and P is tall, P pulmonally. And there is RVH with strain pattern. If we see here, the R is small, that means LV is small. And I already mentioned that if there is severe pulmonary stenosis, antegrade flow to pulmonary is less and LV will getting less blood. So there will be LV small. So this is an emergency and we have to tell that this patient should now 12 months, we will not wait for, not for any weight, not any feature. We just send for surgery, this patient. And last case that this 12-year child, but now saturation is good. Here we are getting that V1 is monophasic or with strand pattern, and there is LV forces good. Why this LV forces good and saturation good? Because this patient developed MAPCA. So MAPCA is giving the pulmonary flow and LV is getting more blood. So LV is good size. So this will be diagnosis with TOF with MAPCA. So I'm concluding my session, just telling some things that this session will help us, because initially the patient are seen by a pediatrician or by a cardiologist, and we the pediatric cardiologists are not much more. So it is a request from myself to all the cardiologists, if the ECG somehow can help, and the red flag that was mentioned by now, if they can identify, they can refer the patient early and the treatable cause can be corrected and patient can save the life. Thank you, sir.
Thank you, Narumappa, for this excellent and elaborate presentation. It's an
Sorry.
I must say. I request Professor Rafiq Ahmed, sir, to start the discussion.
Yeah. Excellent talk. What is the commonest congenital heart disease in Bangladesh?
Sir, ASD, VSD, and PDA in acyanotic heart disease. And in
No, but single one between ASD and VSD, which is common, more common?
we are getting ASD more.
Yeah. So there is a reason I mentioned that. So I think one of the take-home message for us, adult cardiologists or physicians, like if you get a child with a murmur, with a right bundle, think about ASD. And then the early referral is very important. And a lot of times we have this tendency that, yeah, ignore this ECG, it's nothing, just a normal pattern. But I think we should not do this and have it seen by a pediatric cardiologist. That's important, and that's how we diagnose these patients. Don't you think so, Naruma?
Obviously, sir, obviously.
Sure.
I'd like to make a comment, because this is a very complex thing, and we don't do the pediatrics ourselves, but I think we are doing that. Diagnosing these patients early is very important to totally change their whole lifespan. When to correct it, how to diagnose it. And for our cardiology fellows, I think we need to remember one thing. What's happening above the tricuspid valve that causes the right heart enlargement first, right-sided enlargement, okay? Below the tricuspid valve, first enlargement is on the left side. So if you see any echocardiogram for any murmur or anything that you're doing in echo, you see right-sided enlargement, just don't ignore it. Make sure they don't have ASD. Sometimes there's anomalous circulation. You might not see the defect, or you might have to do saline contrast study if you have suspicion that right side is enlarged and you don't see any visual defect on the normal echo. Make sure you go further, saline contrast bubble study, and sometimes if needed, right side in an angiogram to find out why the patient's right-sided heart is enlarged. It's very important. And as we mentioned, that VSD or PDA, that's below the tricuspid valve, left-sided heart will be enlarged first. Okay. And second question, I have one question that you mentioned that VSD, as it progresses, patient becomes symptomatic. It's not very clear, asymptomatic. So that question, I'd like you to elaborate that. Because did you mean that murmur gets less? Then I understand, because the gradient, because initially if the small VSD, you'll hear high-pitched murmur because of the gradient between the right side and left side. But then left heart is going to enlarge. And when the pressure in the right side enlarges over time, yes, you will not hear the gradient because the right-sided pressure is high almost, if it is equal to left side, there's not much movement of blood flow. That I understand, but the symptoms will be even worse. They're not becoming totally asymptomatic though.
Sir,
I didn't understand that point. Yeah.
Symptom depends upon the left-sided
Mhm.
chamber and right-sided
Mhm.
chamber. Initially, there is hemodynamics effect, means when there is small VSD, there is no chamber dilatation, patient may be asymptomatic.
Mhm.
And because there is shunt is dominant, means more than 1.5, the LV chamber is dilated, patient having the symptom of respiratory tract infection, feeding difficulty, and as a part, patient is not growing, growth failure. And when it is progresses, the LV pulmonary vascular obstructive disease developed, then the LA blood will come less and LV will go in normal size, and RV will be dominant, RV will be hypertrophied. The RTI, feeding difficulty, will be improved. That is called honeymoon period, where the patient have no symptom. But when the RV hypertrophied, the patient develops shortness of breath in the future life, the RV type of symptom, shortness of breath, coughing and hemoptysis, and means working capacity will be less. The symptom is changed, but honeymoon period, where I told in 10 years that patient have previous RTI, feeding difficulty. Now mother is complaining, my baby has no RTI, respiratory tract infection. He is feeling well. This is the honeymoon period. And then next he developed the features of RV hypertrophy feature. He will asymptomatic for the period of time, and the symptom also change LV to RV, sir.
Now thank you for clarifying that, because I think a lot of doctors might have that question. Another question I have, a very simple technique sometimes you could use to assess the direction of the shunt, particularly the ASD I'm talking about. Put some pulse oximetry and look at the resting condition and let the walk. And you can see this oxygenation drops as a reversal of the shunt. That's a very simple technique you could use in your office.
Yes, we do, sir. One thing, we give some sit-up or 6-minute walk test, sir. That the patient functionally, sometimes if it is in late stage, the patient cannot complete the 6-minute walk even. And there is a 6-minute walk distance is in a normal person is 360 to 440, sir. And in we walk for the 6 minutes and we calculate how much he can walk. And there is pre-saturation before walk and after walk. And 1% to 2% reduction of the saturation can increase the mortality 4%, sir.
Absolutely.
So these also guide us, tell us the patients that the prognosis of the disease, sir. And which are the borderline cases we do, sir, means say we are getting 92% saturation, and after walking we are getting 80% saturation. There is significant desaturation after an walk or exercise. So this is very bad, alarming sign, and this is better not to touch this patient. Keep the shunt as like.
Yeah, that's a very important point. Thank you.
Sure. Naruma, there is a question from Dr. Chitra Sharma. What is the mechanism of crochetage sign?
There is a crochetage sign, sir. There is a large ASD, there is a large RSR pattern in inferior lead, and when there is volume overload, sir, there is RVOT dilatation, and I told that this is the same mechanism that we get the RSR pattern in V1. This crochetage is in inferior lead, we get for the same things, that RV volume overload, sir. So initial R, then terminal R.
Sure, thank you.